Good afternoon, everyone. It's Friday the 16th of June. It's 1 p.m. in British summertime, London. And thank you for logging on to the major trauma topic of penetrating cardiac injuries and the emergency department thoracotomy. I have my colleague Mr. Sharfuddin Chowdhury. He's a consultant trauma surgeon, a consultant general surgeon, director of the Major Trauma Centre at the King Saud Medical City in Saudi Arabia, and he has his trauma background from his training at the University of Cape Town in South Africa. So I'm going to hand over to Mr. Chowdhury to start the first presentation.
Thank you, Michael. Good afternoon, everyone. Thanks for the opportunity, especially special thanks to TUGSS and special thanks to Michael for his leadership regarding emergency surgery and trauma training globally. Let me share the screen to start my talk. Michael, can you see?
Yes.
Yes, can you see the screen? Yes.
Yes.
Thank you. Let me start. Today, I divided the talk basically in three parts. First, I will talk briefly about my hospital. Then I will present a case on penetrating cardiac trauma. And then finally, I will elaborate the management of penetrating cardiac injury. So King Saud Medical City, where I am working currently, is one of the largest hospital in the region with 1,500 hospital beds, 200 ICU bed, and 100 emergency department bed, which was founded in 1956. It is a designated level 1 trauma center. We admit 2,500 to 3,000 trauma patients per year, of which 1/3 of the patients get admitted under my department. That means trauma unit. We started trauma unit in 2016. Actually, I moved from South Africa. I did my general surgery training and trauma surgery training in Groote Hospital, which is best known for first heart transplant in the world under University of Cape Town. Then I moved 2016 and we started our dedicated trauma unit here in Saudi Arabia. So in 2023, that means until yesterday, this year, we admitted 488 patients, of which 65% has got some sort of chest injuries. In our area, actually, penetrating trauma is not much. Only 4% has got penetrating chest trauma, and we had 2 penetrating cardiac injuries, and both of them were survivor. One of them had cardiac tamponade on presentation. Another one was transferred from another hospital with a stable hemopericardium. So let's start with the case. 20 January 2023 means this year, early this year, a 27-year-old male presented to our emergency department with a staph precordium. You see in the photo, it's just a 2-3 centimeter lateral to the midline on the left-hand side, 6th intercostal space. There is a stab wound. On presentation, he was hypotensive. His blood pressure was 84/43. He was tachycardic, and his heart rate was 132. Also, he had a distended neck veins, and on auscultation, we found muffled heart sound. So we proceeded to ultrasound, which showed, you can see on the photo on the right-hand side, which showed pericardial effusion. So our diagnosis was cardiac tamponade due to the penetrating cardiac injury. So we proceeded to emergency OR. And for the sternotomy, immediate sternotomy, you can see on the left-hand side, I started doing the sternotomy. So I'm dividing the sternum. So you do mainly midline incision over the chest, skin subcutaneous tissue, and go down to the periosteum of the sternum, and then you divide the sternum. Some people go from up down, or some people can go from the bottom up. It depends on how you are comfortable. I was standing on the left-hand side, actually, of the patient. That's why I started from the top to divide the sternum. Then if you see on the right-hand side, I'm opening the pericardium. So there's a gush of blood coming out of the heart. I'm extending the pericardial set. As you see, there's a lot of blood coming out from the chest. Luckily, there was no active bleeding. Means this blood you're seeing actually already bled out into the pericardial sac, but after releasing, after cleaning, there was no active bleeding from the right heart. The stab wound was in the right ventricle. And if you see, we managed quickly to repair the injury of the right ventricle, as you see in the photo. So finally, patient was transferred to the intensive care unit. He was extubated on day 2 postoperatively. And then after removing the mediastinal and pericardial drain, as well as the chest drain on the left side, we discharged home on day 6. Follow-up after a week, no further complications. So penetrating cardiac injuries is a problem with this is high mortality, pre-hospital mortality, almost 86%. But the patients who arrive at the trauma center are potential survivors. We need to just early recognition of the injury. So to early recognition for the injury, we need to screen for the penetrating cardiac injuries. So if you look at there's 3 photos here, which is defining the precordium, cardiac box, cardiac proximity. So normally cardiac box means upper border is the clavicle and lower border is the tip of the xiphoid process, and medially and laterally means both sides is the mid-clavicular line or nipple line. So we used to actually screen all patients who presents to our center with penetrating injury to the cardiac box. But we found we are missing some injury, especially if you have a gunshot injury, which can also means even if it is outside the cardiac box, patient still can have cardiac injury. So we extended our screening to cardiac proximity, which is defined as whole anterior chest and left half of the posterior chest. That means any injury to the cardiac proximity, we should screen for the cardiac injury. How they present normally? They present in 4 forms. Either patient come to you as a stable hemopericardium, or cardiac tamponade, hypovolemic cardiac arrest, or exsanguinating thoracic hemorrhage. Most of the patient who presents to our to the hospital actually last 3 types. That means cardiac tamponade, hypovolemic cardiac arrest, or exsanguinating thoracic hemorrhage. This group of patients actually unstable on presentation. So, and the first group is stable hemopericardium. Problem with the stable hemopericardium, this can be a diagnostic challenge, and the patient may be remarkably stable. Warning signs can be a period of brief hypotension in the pre-hospital or tachycardia. So sometimes even such a small penetrating into the anterior chest wall, they go to a general physician even, or even a small hospital, primary healthcare. And as the patient is stable, most of the time they get actually discharged from the hospital. But in such case, we can miss the injury to the heart. So I'm going to discuss first stable hemopericardium, how to diagnose this, how to manage this. And then the next, I will discuss about the cardiac component and other. So let's start with the stable hemopericardium. How to approach to a stable hemopericardium. So as we know, any trauma patient comes to your emergency department, we start with ATLS principle. After initial assessment and resuscitation, we do the diagnosis, and then we admit the patient to a high dependency unit, such patient, I'm talking about the stable hemopericardium, or in ICU for continuous monitoring. Then we prepare for him or her for theater. So how to diagnose these cardiac injuries? So we can use central venous pressure, we can do a chest X-ray, we can go for ECG, electrocardiogram, ultrasound heart, even we can do echocardiogram or CT chest. But subxiphoid pericardial window is actually gold standard for diagnosing the penetrating cardiac injuries. Central venous pressure, any venous pressure, if you have a central line, then you can measure central venous pressure in your emergency department. So any pressure above 12 centimeter water, you have to think about penetrating injury, it means to the heart, or elevation out of proportion to the systolic blood pressure. But problem with the central venous pressure, it can be elevated due to tension pneumothorax, overzealous fluid resuscitation, even straining or pain can give you high central venous pressure. So it's not a reliable investigation tool in terms of diagnosing cardiac injury. Secondly, if you do chest X-ray, what can you see? You can see pneumopericardium if pericardium is breached. So you can see air in the pericardium. Or you can see even straightening of the left heart border, especially because of blood in the pericardial sac. The aortopulmonary window can be obliterated on the left hand side, which gives you straightening of the left heart border. And globule, obviously, if you have a large pericardial effusion, in the X-ray, you can see the globular heart shape. During 2021 to 2009, actually, I was at that time, I joined the University of Cape Town in 2006. So when Professor Nicol and his team was running this study, I was a general surgery resident there. So they found between October 2001 to 2009, February 2009, 162 patients, they found straight left heart border, which is sensitivity 40% and specificity 84%. So although this is not highly sensitive, but you can see highly specific for cardiac injury. Thirdly, you can do an ECG. ECG might show J-wave. What is J-wave? J-wave is a positive deflection after the QRS complex, or even ST elevation. So in our series of 174 patients, we found only the patient only 44% sensitivity and specificity 85% for J-wave. So the next is we do ultrasound heart. So what we look for? We look for basically pericardial effusion. So in our series, we found 87% sensitivity and specificity. That means very high sensitivity for ultrasound heart. But problem with the ultrasound heart, you can be confused if there is associated hemothorax. So what we used to do, if you have associated hemothorax and patient is completely stable, and still we used to repeat the ultrasound after 24 to 48 hours to make sure there is no pericardial effusion or effusion. Alternatively, you can go for CT scan, which is highly sensitive, or even you can do the subxiphoid pericardial window if there is a pericardial effusion. That means hemopericardium. So this is one of my current. That means recently I did this pericardial window for one of our patients. who presented to our hospital, what do you call it, as a stable hemopericardium. So we just opened the pericardium and we waited for some time and we drained the pericardial sac. We did not do the sternotomy in this case. So during that time, I'm talking about during before 2013, every single patient with pericardial effusion used to have sternotomy, invariably all. But then we run the one randomized control trial, which is the first time in the world, of 111 patients, of which like the patient who goes to theater for subsequent pericardial window with a positive blood in the pericardial sac, we randomized in two arms. That means one for sternotomy, another one for pericardial drainage. So 55 patients was in the sternotomy group and 56 patients were pericardial drainage group. So sternotomy group, we found no cardiac injury or tangential injury for 51, which is 93%. And we found 7%, that means 4 patients had sealed endocardial injury. And 1 patient died in this group for severe cardiac injury. Anyway, so we concluded that stable patients with hemopericardium detected after penetrating chest trauma can be safely managed with pericardial drainage by a subxiphoid pericardial window as opposed to median sternotomy. This was a landmark trial, actually. After that, whole the management system changed globally. So nowadays, if we have a pericardial effusion and patient is with stable hemopericardium, we do the subxiphoid pericardial window, and if there is no bleeding actively, we drain the patient. We don't open the chest. So now I'm going to talk about cardiac tamponade. So how they present? We know cardiac tamponade will present with hypotension, especially systolic blood pressure less than 90 millimeter mercury, distended neck veins due to increased JVP or jugular venous pressure, or muffled heart sound. But with these 3 signs, we call it Beck's triad, actually. I think most of us, we know that. Only 45 to 75% patient can present with this. So it's not very, not very sensitive also. That means to diagnose cardiac tamponade. Another thing we can find, pulsus paradoxus, 11% of the patient. So this is not also very reliable for diagnosing cardiac tamponade. So what about if you find a patient with cardiac tamponade? What next? What about pericardiocentesis after cardiac tamponade? So obviously you have to decompress the pericardial sac to save the patient, but we found that this is unreliable. False negative rate is around 10 to 80% and false positive rate 10%. So pericardiocentesis nowadays, especially in level 1 trauma center, the role is very limited. There was a systematic review which was published in Journal of Trauma and Acute Care Surgery in 2013. They found the use of pericardiocentesis for trauma is limited and biased towards survivors. There remains a limited role for pericardiocentesis in non-trauma centers, where definitive surgical management is not immediately available, and transport time to a higher level of care facility supports using temporary decompression by pericardiocentesis. So if you don't do this, what options we have? That we have to decompress the pericardial sac. So we can proceed to either emergency room thoracotomy, emergency department thoracotomy, or if patient can travel to OR very quickly, we can do either thoracotomy or sternotomy, depending on situation and surgeon's preference. So what are the indications for emergency department thoracotomy? I think Michael will elaborate on this topic. So I'm not going to tell that much on this. Just if patient is asystole with signs of life in the preceding 5 minutes of pulseless electrical activity on ECG monitor with cardiac arrest, or patient present with hypovolemic cardiac arrest, or he will not survive, his hypertension will not survive even 10 minutes delay transfer to theater, or chest drain is more than 1.5 liter, on insertion, continuously bleeding more than 200 ml per hour, we go for emergency room thoracotomy. So this video I'm showing now, I got it from my prof from Groote Hospital, University of Cape Town, just to show you how to do an emergency thoracotomy. You can see there's an incision in the intercostal space, just lateral to the, from the sternal border to the mid-axillary line. Just make sure the medial side not to injure the internal mammary artery, which runs parallel to the sternal border. So you go down to skin, subcutaneous tissue, then pectoralis major muscle divide with the knife, up to the intercostalis muscles. You can also bluntly dissect with your hand. Then you can use a Finocchiati retractor to open the chest. Then you just pick up the pericardium and open the pericardial sac. But be careful here, phrenic nerve runs parallel from up to down. So your aim should be to the right shoulder upwards. No, and sometimes it could be difficult to pick up the pericardium because of blood in the pericardial sac. It can be very tight, and it's like a very tough structure, a pericardium. So sometimes you can use 11 blade to just open the pericardial sac. You can do also cardiac massage if you need through this procedure, or even you can inject adrenaline in the intracardiac chamber, especially in the right ventricle, if you need. And also you can use the pedal to, if patient will go into the shock, then you can use DC shock. This 10 joule normally we use for cardiac. So, in briefly, what are the take-home message? If you find any patient with penetrating chest injury within the cardiac proximity, you must screen the patient for penetrating cardiac injury, especially with chest X-ray. You look for straight left heart border, you look for globular heart shape, or even you look for pneumopericardium in the chest X-ray. Then you must do an ECG, and ECG may show a J wave. You also look for ST segment elevation or ECG changes. Then you go for ultrasound. Ultrasound may show pericardial effusion. If there is pericardial effusion and if patient is unstable, immediately you decide about surgery, which can start from the emergency room thoracotomy up to the sternotomy or even OR thoracotomy. If patient remains stable, normally you admit the patient in the intensive care unit or high dependency unit. After 24 to 48 hours, you prepare patient for subxiphoid pericardial window, and you do subxiphoid pericardial window. If patient has positive blood, you wait. If there is no active bleeding after washing out and waiting for a couple of minutes, usually we used to wait for 5 minutes. There is no bleeding or there is no active oozing or something like that, you can just drain the pericardial sac and come out. And if there is bleeding, you must open the chest through the sternotomy. That means you have to prepare the patient for sternotomy in case if you need. Thank you. Thank you, Michael.
Thank you, Sharfuddin. If you could stop sharing your screen. And what I'll do, we have had one question posed, but I will carry on with the presentation that I was going to give, and then we'll address questions at the end. If there's anybody in the audience who wishes to pose an additional question, now would be a good time to do it. So just give me 1 second and I will share my presentation. So for those of you who don't know me, I'm Michael Wilson. I'm an upper GI surgeon. I'm based in Scotland, but I'm also a major trauma surgeon in London, and I'm actually here this week. I do that as part of my job plan on a 1 in 12 rotating basis. And what I'm going to focus on is the indications and, more importantly, what the outcomes are for emergency thoracotomy. And when we talk about emergency thoracotomy, what we're looking at here is pre-hospital and emergency department thoracotomies, or patients that have been taken to theatre to have an emergency thoracotomy in the emergency theatres. So we're going to define what a thoracotomy is, when to perform a resuscitative thoracotomy, and perhaps more importantly, when we shouldn't do it, because we're going to talk about both blunt and penetrating injuries. And then we're going to look at the literature. What does the literature say about how successful a thoracotomy is in that emergent setting? So, what is an emergency thoracotomy? So what we talk about is an emergency or a resuscitative thoracotomy being life-saving, performed at the site of injury. That's when it's in the pre-hospital setting. And just a few months ago, I'm sitting outside St Mary's Hospital. The HIMSS team did a thoracotomy in the street, just 50 yards away from me, and perhaps 200 yards away from the emergency department here at St Mary's. And that patient survived. So the other way to do it is that when they arrive in the emergency department, it's deemed that they're not fit enough to be transferred to the operating room, and so they get a thoracotomy in the resus bay. And that is when a patient presents in extremis from a life-threatening injury. It's most often it's a thoracic injury, but I have done a couple of thoracotomies for patients who with gross exsanguinating pathology distal to the thoracic cavity. So, in the context of major trauma, we need to remember as well that this actual knife to skin and performing the thoracotomy is a single part of a huge process called damage control resuscitation, which involves all of the major trauma team, our anaesthetists, the ED nurses, who are filling up, getting the Belmont, filling the patient up with blood, and replacing clotting factors. So the actual surgical part of the procedure is perhaps, whilst it's crucial, it's not the only part of the process that will save your patient's life. So when should you think about doing an emergency thoracotomy? And Sharfuddin alluded to it earlier. So in the context of major trauma, what you really want to hear from the paramedics at the handover, or even if you're on the street. I've never done one in the pre-hospital setting. I don't do pre-hospital medicine. But if you are a pre-hospital emergency care provider, what you want to hear from a witness is that that patient was moving, breathing within minutes of you getting there. You want to know that there's evidence of a penetrating thoracic trauma. You want to have evidence that there's hypotension, which is not responding to aggressive volume resuscitation. So we call them the non-responders. And then also as well, our pre-hospital colleagues will quite often do bilateral thoracostomies. And if you've got blood pouring out of these thoracostomies, then you need to proceed directly to connecting those wounds up and doing a clamshell thoracotomy. And I alluded to it earlier, there are some indications to gain major vessel control by opening the chest in order to get control of the distal thoracic aorta. So this slide talks about when should I not do an emergency thoracotomy. And I would say that this is controversial, but by the end of the presentation, I think I can qualify it by saying this is perhaps only a little bit controversial. And the reason for that is that I conclude that it's generally accepted that a resuscitative thoracotomy in the context of blunt trauma and no witness signs of life or absence of electrical activity of the heart should not be done. It is not indicated. So when should you do it? So you do it when you want to gain control of major exsanguinating hemorrhage, when you want to release a cardiac tamponade, when you want to perform internal cardiac massage, and when you want to clamp the descending thoracic aorta in order to get control of major exsanguinating hemorrhage distal to the thoracic cavity. So, what do the papers say about when we do a thoracotomy, what are the outcomes? So I picked a few papers published in the last 10 years, which goes over clinical outcomes. And so the first paper here was written, published in the European Journal of Trauma and Emergency Surgery in 2016. And it's about emergency resuscitative thoracotomy in European civilian trauma patients with blunt or penetrating injuries, and it's a systematic review. So they describe outcomes for 376 thoracotomies, and 51% of them were for blunt trauma. Overall survival for a resuscitative thoracotomy was 42%, but this is where you get down to the nitty-gritty. The clinical outcomes for survival in thoracotomy for blunt trauma is 12.9%. If you do an emergency department thoracotomy for penetrating trauma, your survival is 41.6%. That's almost 4 times higher. If you do an emergency department thoracotomy in a Canadian major trauma centre, then what they've described is an overall survival of 10%, and their thoracotomy survival for blunt trauma is as low as 2.9%, and for penetrating trauma is 20.8%. Now, you can see quite significant differences there, but that is likely to reflect the frequency of major trauma in a Canadian population versus a European population. And there'll be many factors which play into that. So here's another systematic review that looks at a systematic review of 3,251 emergency thoracotomies, and this was published in the European Journal of Trauma and Emergency Surgery back in 2018. It included 37 papers looking at emergency department thoracotomies with an 8.5% overall survival. So what it showed is that if you had penetrating trauma, your survival was higher at 10%. And if you had blunt trauma, then your survival was 5%, given with an odds ratio of 2.1. If you were stabbed, then you were much more likely to survive compared to if you had a gunshot wound. So your stab wound survival is 23.6% versus gunshot at 5%. And I think that just reflects the nature of gunshot injuries and the tunneling effect that you get from bullets inside the chest. If you have a primary cardiothoracic injury and you're doing an emergency department thoracotomy versus a non-cardiothoracic injury, so for example, massive exsanguinating hemorrhage from the groin, for example, then there is no statistically significant difference in clinical outcomes. It's roughly about 10%. If you have signs of life when you arrive in hospital, you're much more likely to survive. So your survival, if you've got signs of life on arrival at hospital, is 14.6%. But if you've got no signs of life and you decide for some reason to proceed to a resuscitative thoracotomy, your survival is at 3.1%, and that's an odds ratio of 5.3. If you've got signs of life in the field, then again, doing a thoracotomy will give you a high survival rate versus no signs of life in the field with a rather dismal 1.1% survival. So this paper is interesting because it actually focused on neurological outcomes for survivors. So in emergency department thoracotomy patients, they report that in their 37 papers within their systematic review, that just shy of 80%, so 4 in 5 patients, are neurologically intact. Now, you could argue whether that's the best marker of a successful outcome or not, because it doesn't tell you whether they get back to full employment and whether they contribute income to the taxpayer via the taxation system. But I think in terms of a better marker of clinical outcome, looking at neurological outcomes, that is a reasonable marker. So this paper is also interesting, and it's from 2018, and again, the European Journal of Trauma and Emergency Surgery, and it's looking and focusing on pre-hospital resuscitative thoracotomies. It has a look at case series, case reports, primarily from London, and what they find is that there's an 18% survival for penetrating trauma. If we look at pre-hospital thoracotomies for blunt trauma, there's only one paper that was out there when I last looked at this. I had a quick look again this morning and I couldn't find anything else. But when I properly looked at this back in 2020, there was only one Japanese paper that reported a pre-hospital thoracotomy for blunt trauma and nobody survived. And there was only one case report of a survivor in another publication for blunt trauma. And interestingly, what they didn't do is they didn't describe in great detail any specific case details in that case report. So, in summary, what I've tried to do is summarise, based upon evidence in the literature, when you should think about doing a thoracotomy. So I don't think there's any doubt from the published literature that your best outcomes from an an emergency department thoracotomy are for penetrating trauma when you have signs of life at hospital. Poorest outcomes are for patients who have a thoracotomy as a result of blunt trauma with absent signs of life. And the more recent literature is suggesting that we should not be considering a thoracotomy for blunt trauma at all. And if we talk about pre-hospital thoracotomy, the only indication appears to be for penetrating trauma with signs of life. And clearly, since this has been looked at and these papers were published, what we've got are REBOA papers and evidence being submitted for external scrutiny. And that's a whole separate talk in itself. That's the end of that talk. So what I'll do is I'll stop sharing my screen. And that completes the scheduled presentations for today. And what I will do is I will go to the questions. So we've had 2 questions. And Sarah has asked Sharfuddin, and I thought it was a valid question. For the first patient, why did you not do a left lateral thoracotomy to access the heart instead of sternotomy?
Thank you, Sarah. It's an interesting question. I was expecting the question also.
Yeah.
First of all, if you look at my patient, so maybe my patient anywhere else in the world will end up in emergency room thoracotomy even. If you do not have good hospital setup, especially access to the theater, or you are not very familiar with such patient, because even in Saudi Arabia, we see 1-2 patients a year. But in other way, like in Cape Town, we used to see 2 patients a month. So there's a huge difference. So luckily, this patient was maintaining the blood pressure. So I could take him to theater. Because even from Michael's presentation, you already understand the outcome from the emergency room thoracotomy is around 20%. In our series, even in Cape Town series, 38%. But if you can take the patient to theater, the survivor goes up to 86%. So next question, I took him to ward. Now, why I did sternotomy instead of thoracotomy? For the general surgeon, actually, I think this patient, you would end up in thoracotomy, sternotomy. You need also expertise to do it, number 1. Number 2, any injury to the medial to the mid-clavicular line. If you look at my patient, it's very close to the midline, 2-3 centimeters, 6 intercostal space from the midline. So I was expecting some right heart somewhere injury. So if you can do sternotomy, you can have better access to the heart as well as the superior mediastinum, even great vessel, because you don't know the tract, right, of the injury. So that's why, and I can get access to the cardiac cavity within like 5-6 minutes. So for me, for myself, going into the chest through the thoracotomy or through a sternotomy, it's not a big deal. It's almost equal. But due to the access, I decided to take do the patient because he was maintaining the blood pressure. I could easily access to the cavity. And in case maybe I need to open the superior mediastinum. So in those areas, especially midline, median sternotomy is the best. But say, for example, you end up in same patient, you started with the thoracotomy. So maybe you have to do, I can see the next question, when clamshell. So you can end up in, because, yeah.
Do you mind if I just mention?
Yes, you answer. What I'm saying,
Hmm?
Sarah, if you do the stenotomy, means thoracotomy, maybe you end up in, because you cannot access other side, so you may end up in clamshell. But due to I did the stenotomy, so I managed the heart very quickly and easily. So it depends on the expertise, depends on the situation, how quickly you can enter into the cavity. Thank you.
Yeah, so my take on that one is that if that patient was in my hands with the training that I've had, which is not as extensive as Sharfuddin's, I don't have his years and years and case after case of experience, is that I would do a clamshell thoracotomy for that patient. It's the quickest, it's the easiest, and it's the safest. And my strong advice to anybody on this call who hasn't been specifically trained to do a sternotomy is not even consider it.
Yes, especially for the general surgeons.
Yes.
I advise you to do this straight away thoracotomy. Don't even think about stenotomy. Straight away thoracotomy.
When you've got somebody like Sharfuddin who's been trained for years and is an expert in access to the chest via sternotomy, it's a valid entry route. But for a general surgeon who is dealing with a patient at the extremes of life with no experience of sternotomy, your only option is either a left-sided thoracotomy or a clamshell thoracotomy. And that takes us nicely to the next question from Mohammed, which is, do we have any rules, I'm assuming any rules or tips for how to do a clamshell thoracotomy in penetrating cardiac injuries? So I can start this one off. It's dead easy. So I was a fellow here at St Mary's 5 or 6 years ago, and as a consultant, I've maybe done 10 or 11. I've been involved in about 20 thoracotomies from the emergency department up into the emergency theatre. And my one tip for you is that if you've got a patient who's been coming in from the, you get a pre-alert that says stab chest, the best advice that I got is go to the drawer in resus and take a blade and put it in your pocket, because you've got no concept of what you're going to be faced with when that patient arrives in the emergency department resus bay. You set up 2 intercostal chest drains. You don't need to open everything up and waste lots of money, but you have 2 trolleys set up so that you are good to go to immediately do bilateral thoracostomies and extend them into chest drains. And then clearly, if your patient is in extremis, take your knife out of your pocket, you speak to your anaesthetist, you talk to your trauma team leader, and you offer to do an emergency department thoracotomy. And there's from my point of view, if you've got somebody who is competent to assist you, then you do one side each. So if I'm the senior surgeon, I will be doing the left thoracotomy, and my less experienced colleague will be extending my excision from the midline and doing a right-sided thoracotomy. And then what I reach for, which brings us on to the third question about the quickest way to cut through the sternum. So if you're doing a clamshell thoracotomy, what you do is you ask the nurse to get you a pair of tough cut scissors. So if you don't have tough cuts, you ask for plaster cast scissors. Never mind saws, because if you don't know how to use them, it'll take forever. Get a pair of plaster cast scissors, and in one big swipe, you will go straight across the sternum. It will snap and it will open up like the clamshell that is described. The way you do it is exactly the way you saw in the video, is that you aim roughly from the medial border of the sternum and you extend your excision boldly at roughly the level of the 5th intercostal, below the 5th nipple. Sorry, not below the 5th nipple, below the nipple. And that's roughly at the 5th intercostal space. And you extend your incision all the way down onto the bed. If you try to do it through a minimal incision, your chest will not open up. You must extend your incision all the way down into the bed. Sharfuddin, do you want to add anything to that?
No, thank you. Excellent explanation. I agree with you 100%.
Okay, in terms of, I think we've addressed most of the questions. Sarah has said, you're absolutely right. Here in Oman, we don't get many injuries often. I'm a general surgeon, so clamshell thoracotomy, thank you very much. Are there any final questions from anyone else before we draw a close to this presentation? Whilst I wait for any final questions, what I'd like to do is thank my colleague Sharfuddin, because he was given the monumental task of teaching us how to deal with penetrating cardiac injuries, and I think he's met that with aplomb. I got the easy task of reading 3 or 4 papers and copying and pasting some percentages and telling you what the clinical outcomes were. So with that in mind, there's been no further questions. I'll bring an end to the presentation, and thank you once again.
I think Sarah asked some question.
Oh,
Last, you want to take Sarah?
Okay. How about
thoracotomy
thoracotomy in a penetrating injury in a cardiac arrest patient?
Yes, of course. You do ED thoracotomy. That's what she's saying, right? Or...
That's my take on it. I think it's exactly what we just described. That's the quickest way. Clamshell thoracotomy. Start off in the left if you're on your own, then run round and do it on the right-hand side. I've never had to do one on my own, and there's always 2 people around. And you can be talking your less, even if they've never done it before, you can be talking through your junior colleague through the right side as you do the left. Oh, another bit of advice, and again you saw it in the video, was the Fenichettio retractors. Always have the handle closest to the bed. Don't put the handles up on the sternal side, because when the clamshell happens, you'll get in all sorts of mess. And then the first thing to do when you open up the clamshell is get control of the internal thoracic arteries, or the internal mammaries if you talk old money, because they will bleed like bilio, and you will actually get probably even greater blood loss than what you'll get from a cardiac tamponade.
I think there is another question from Jesse. If you want to read.
Sure. So may I know, for a clamshell thoracotomy, wound extension will be at the right 5th intercostal space, or would the 4th be an option? My personal view is that I think the 4th, you're not going to be able to expose the heart quite as well. But perhaps if you know that the injury isn't to the heart, and that it's to the, and again, I have no actual hands-on experience of this, but if your injury is to the outflow of the heart at the aortic arch, and you don't have a vascular surgeon with you, and again, you're not equipped to do a sternotomy, then perhaps you want to move 1 rib space up to get better access to the upper level of the thoracic cavity. But that is when you're talking about patients who are probably going to die.
So yes, of course, 50 is the best standard. But if you go 4, still you can access. I think it's not a big deal. But maybe 3 is too high.
Yeah.
4, 5 is, but 5, I recommend 5.
I think
standard.
5, and in a male, it's very easy. It's basically just below the nipple. Women, obviously, slightly different. If you have a woman, then effectively you're following the curve of the
mammary lines.
That is what you're going to follow as you make your incision. You basically get somebody to hold up the breasts for you, and you make your incision from left to right, following the curve of the inframammary fold, and that will be roughly the 5th intercostal space.
Yeah. Thank you.
Right. I think that we are done, and thanks everyone again for attending, and this will go up on the YouTube channel. Give me a few days and you'll see it appear. Thank you very much.
Thank you.